a case of newly diagnosed decompensated heart failure versus sepsis diagnosis, a crucial differential during medical floor admissions. Background, both sepsis and acute decompensated heart failure can present with organ dysfunction. As we know, this is due to different reasons in each. In sepsis, this is due to a dysregulated host response to infection, and in acute decompensated heart failure, it is due to structural or functional changes in the heart, leading to an inability to meet the metabolic demands of the body. Lactic acidosis is rare in acute decompensated heart failure. In fact, Adamo et al. Found that lactate levels were normal in about 75% of the patients in their study that presented with acute decompensated heart failure. So we present a unique case of newly diagnosed acute decompensated heart failure with lactic acidosis. A 65-year-old male patient with history of tobacco and alcohol abuse, obesity, hypertension, hyperlipidemia, diabetes, and atrial fibrillation, presented with mild shortness of breath, bilateral lower extremity edema +1, and noted cyanosis in the first and third digits bilaterally. The white blood cell count for him was 12,000, lactic acid 9.4, BNP 2,271, and creatinine of 2.7 with a baseline creatinine of 1.5. So the patient met sepsis criteria with multiple organ dysfunction. And at that time, we were thinking maybe the urine was the source of infection and the urine culture was pending and the urinalysis was positive. The management, due to the potential fatal consequences of either diuresing a septic patient or aggressively fluid resuscitating a patient with heart failure, we started the patient on 100 milliequivalents of potassium bicarb with D5W at 75 mL per hour while obtaining further results. And after giving the fluid challenge, the patient's labs worsened, the clinical picture worsened as well. So this kind of led us to a diagnosis of acute decompensated heart failure. So we started treating him with Lasix at this point, which led to clinical and laboratory improvement. And then the echocardiogram eventually revealed the ejection fraction of 40 to 45%, the TAPC of 1.4, and the RSVP of 24. So this case is interesting because it highlights the limitations that we have with sepsis, as they don't always identify patients with organ dysfunction that is truly secondary to an underlying infection. Sometimes sepsis can only be diagnosed or ruled out after we get all the laboratory, radiologic, physiologic, and microbiologic data. And during this turnaround time, and when there is a mixed clinical presentation, physicians need to have a comprehensive and conservative approach to their management. Because as we said, we don't want to diurese a septic patient, but we don't want to aggressively fluid resuscitate a heart failure patient. The use of central venous pressures, pulmonary occlusion pressure, and POCUS, they might increase the speed and accuracy of diagnosis, but those imaging studies and procedures are invasive, not always readily available, and they also have several limitations. So the conclusion of this is significant lactic acidosis due to heart failure is rarely described in the literature and can be a confounding factor when we are admitting a patient with a new diagnosis of this and a mixed clinical presentation. And for this, a comprehensive evaluation of the risk, benefits, and the effectiveness of fluid infusion allows for patient-centered care rather than following a fixed, restrictive, or liberal strategy. And thank you for your time.
Perfect. Thank you, Sophia. And a question for you would just be, what's the mechanistic reason as to why acute decompensation heart failure can cause lactic acidosis?
Yeah, because the heart is not pumping enough blood to supply the metabolic demands of the body. And you would think, like, based on just the physiologic mechanism, you would think, oh, the patients would have lactic acidosis because they are not meeting the oxygen requirements and the metabolic demands. But interestingly, as the study from Adamo et al. Shows, on like 75% of patients with acute decompensated heart failure, they have normal lactic acid levels. So when we see a lactic acid that is very high, we usually tend to think this is like a sepsis diagnosis or some sort of infection, but that's not always the case.